So I'm going to introduce our next facilitator, who will introduce the panel that's coming up next to talk about patient-mediated exchange. I have the pleasure of introducing Lee Stevens, who I've known for many years. He's currently with the Office of Policy, leading our state interoperability policy efforts. But he's also the acting director of the certification program. He had worked extensively with our state work and our HIE efforts to promote exchange of health information, and has been involved in this space for a long time in working with states, with the State Governors Association, and working with our office even well before he was part of ONC. We're thrilled to have him as part of our ONC family, and please join me in welcoming Lee Stevens to the stage.
So I want to go ahead and invite the folks to come on up to the stage. We're going to show you a really incredible video from our PHR Ignite project down in Dallas. And when we were thinking about how to, this goes way back. Lygia and I we had a bunch of meetings, and we were trying to think about where we can get a hospital to really give patients their data unencumbered, completely outside of all portals. Patient owns it, exactly what the vision of consumer-mediated exchange is. And we realized we have to go somewhere where people can get really riled up, because this isn't going to be so easy the first time. And so we went to Texas, naturally. And so sticking with our Texas theme today, we're going to first show the sickle cell anemia patient-mediated exchange video from Children's.
When I found out she had sickle cell, I cried for her. I didn't want that for my daughter. I never heard anything good about sickle cell, and you don't want your child to go through any kind of pain.
Children's Medical Center of Dallas is celebrating our 100th year. Our mission is to make life better for children. We care for children that are scattered throughout the state of Texas who have chronic illnesses. We saw a gap. We saw our children being cared for in other areas without complete information. We wanted, with our Personal Health Record project, to be able to provide a solution, to have their clinical information available to them regardless of their location.
The Office of the National Coordinator for many years has really been focused on enabling health information exchange across the country, and the technology is at a point now where really we have a moral obligation to harness it and to make the lives better for patients.
Sickle cell disease is a disease that impacts many organ systems throughout the body. It's a complicated disease. The benefit of having an accurate reflection of what's going on in terms of active problems and in terms of medications and in terms of recent healthcare encounters, that's really invaluable when you're going to be encountering people that don't necessarily know your story from birth in the way that we know their story from birth.
Doctors up here, they're good, but they do not understand sickle cell. But with the app now, it's so much better. I have documents, and it's not hearsay. And when I show them, they know that this is real, and this is what's going on, and her records is right in front of them.
The type of patients that are in this pilot program, they have chronic illness, and it's something that they're going to have to deal with from birth to the rest of their life. trying to manage that, trying to remember everything you've been on, every medication, every treatment, any surgery, etc., is really difficult to manage. You know, you get stacks of paper from one doctor and then you get another stack from this doctor. How are you supposed to keep that all together? What we've done is kind of given them one source, one location to keep that information all there. So immunizations, medications, even insurance information. And it's on something that's already kind of integrated itself into our lives. When we can give them those tools and a device so they can look at their children's medical records, they feel empowered. They just keep looking at their kid and smiling because they know there's one more thing they can do for their kid to make their life just a little bit easier.
This pilot at Children's Medical Center fundamentally changes the role of the patient. We believe this gives them the opportunity to own their data, to control it, to learn more about how they're doing, and to coordinate their care across all these providers. I think everybody understands the value here, and they're excited about the path ahead.
I really thank y'all and Children's with the program because it really does help.
So we're really excited and very proud of this opportunity down at Children's. It took a lot of work to really get this data out of the EHR. We had a great partnership with Microsoft working with Children's to help support this effort, and with Verizon donating phones that these parents could use. When we started thinking about empowerment, and that's a word that comes up a lot when we talk about consumer-mediated exchange, this mother said a little bit more than what we showed in the film. She said that when she takes her daughter to an emergency room in the middle of the night, and historically she has tried to tell the folks in the hospital what's going on with her daughter, what kind of treatment she might need, that she felt like they thought she was stupid. That was a turning point for me, because I realized right then and there that we're talking about a very different kind of empowerment than what I originally thought. This mother now feels much more safe, and she feels a better trust relationship with her daughter's caregivers in a clinical situation. And I think the second thing that we really learned from this pilot that was so powerful and really got me thinking about how, a lot of people have thought that you needed an Ivy League education to be able to use this kind of technology, that it was too complicated, that people might not really get it. This mother can use Health Vault as well as anybody in this country. She grasped on to how to use it right away. There are no barriers to personal health records in this country right now. People can use them. All they need is an internet connection. They can get their data anywhere, anytime. And so this was a really breakthrough moment for us. And with that, and what we're going to do now is this on? We're going to talk to some folks who are making it happen in similar ways, different places across the country. And this is, to me, an exciting panel to moderate, because we can only talk about how awesome this is going to be for so long before we actually have to do it. And these folks up here are actually doing it today. So let me introduce Laura McCrary. She's the Executive Director of the Kansas Health Information Network. Mark Haney, the CEO and founder of Get Real Health. Gilbert Salinas, a fellow with the Institute for Healthcare Improvement. And Dr. Tim Burdick, the Chief Medical Informatics Officer at Ochin. Why don't we go down the row here and have each of you talk a little bit about what your organizations are doing and how you're engaging consumers.
Thank you, Lee. My name is Tim Burdick. I'm with Ochin. Ochin is a health-centered information network based in Portland, Oregon. We run one instance of an electronic health record used primarily in the safety net clinics in 22 states, mostly community health centers, federally qualified health centers, and rural health clinics. We have rolled out a patient portal over the past couple years. We're starting to do open notes with that, as well as labs, immunizations, problem lists. We're also starting to collect through the patient portal some patient-reported outcomes, depression screening, social determinants of health, that we're using both clinically as well as in some research projects through PCORI.
Thank you very much. Laura?
Hi, my name's Laura McCrary, and I want to thank you for inviting me to come from Kansas today to spend a couple of minutes talking to you. I run a health information exchange in Kansas. It's a statewide exchange. We connect currently 282 different organizations that are sending data using lots of different disparate EHR systems across lots of different healthcare organizations. We have just about 5 million patients that you can access through the exchange, and we provide sort of the standard health information exchange services, including direct, which is secure clinical messaging, query-based functionality so that you can search for patients across our exchange and then across our surrounding states' exchanges. And then one of the things that we also do is we provide a free personal health record for all patients in Kansas who receive care in Kansas. And so we started that last October when we rolled it out. We did what was called a soft launch so that we could kind of work out the bugs with it. And we had 16 different organizations that agreed to be the pilot sites that range from individual physician practice up to a mid-sized hospital, about a 200-bed hospital. So we have been working out all of the bugs over the last year, and one of the things that we found is that if you can't provide the information directly to the patients about their health care, it's really a challenge. And so we have now getting ready to start what we call phase 2, where we're going to bring all the information from the exchange, that we're gathering from 275 hospitals and physician practices and FQHCs and community mental health centers, and deliver it directly to the patient so that they get a notice real time that new information is available in their exchange personal health record. And it crosses all of their providers. It's not just one provider. All their information is available in one place. So we're really excited about that, and I'll look forward to telling you a little bit more about it.
Great. Mark?
Thanks. Good afternoon. My name's Mark Haney. I'm CEO and co-founder of Get Real Health. We make a patient engagement platform that allows hospitals and other healthcare provider organizations to engage with their patients around their health. And that begins with giving them their information, but that's certainly not where it ends. So basically, what happens is the patients can access their medical records via their mobile device or with a web browser. But they can also go ahead and communicate with the providers, get care information, get educational information, get their information in a meaningful and understandable way, and basically really get a chance to understand their overall health picture. Another thing that we focus on is not just being the place where you get the information from just that doctor or just that hospital, but giving you a place to put all of your health information and collate it together in a way that you can understand. So we connect with Microsoft Health Vault and other data sources. We can bring in Blue Button data, direct data, and we're always open and looking at new data sources, whether it be Apple Health Kit or Google Fit or whatever's coming down the road, because health information comes in a lot of different forms and from a lot of different places.
Thanks, Mark. And Gilbert?
Thank you. Thank everybody for being here today. I have a dual role here, so I'm going to go into my patient perspective, and then I'll talk a bit about my professional career. By way of introduction, I am what you would consider a very complicated patient. I have so many chronic things going on that there might be too much to list, but lucky for you, I actually made a list. So I'm going to read it to you. So I have tendonitis, osteopenia, arthritis on my entire spine, rotator cuff syndrome, partial paralysis, a neurogenic bladder, chronic pain, and a degenerating lumbar. And of course, we all know that sitting is the new smoking. All this is secondary to a accidental gunshot wound that I suffered at the age of 17 years old by one of my best friends as a kid. I actually grew up in a neighborhood, in an environment where it was safer to send your teenage kids to the military during a time of war than it was to keep them at home as teenagers. In my professional career, I'm actually a chief clinical officer for the same hospital where I did my rehabilitation and therapy after my injury. I now sit on executive leadership there, where we're transforming healthcare in many ways with electronic health records, but mostly with quality improvement and really enhancing how we provide care, pulling away from asking the question, what is the matter with you, to really what matters to you.
Thank you. Laura, we're starting to see a lot of health information exchanges across the country really think about offering PHRs as a service. What really made you decide to do that at Cahan, and what kind of benefits are you seeing?
Well, it's interesting. We began creating a health information exchange in 2009. The Kansas Medical Society and the Kansas Hospital Association came together, and there was really never a time that we didn't always plan on having a personal health record as a part of the services that we offered. And as a matter of fact, as we started working with our state and building the capacity around health information exchange, it in fact is a requirement now in Kansas. If you're going to do health information exchange business in Kansas, you must offer a free personal health record to any patient that receives care in Kansas. So it was never really a question of if we were going to do it. It was more a question of how we were going to do it. And providing a personal health record, utilizing a health information exchange, is pretty complicated. And I think we may be one of the farthest along, but we've really learned a lot of lessons as we've gone through this. And one of the things that is really significantly challenging is patient matching across all of the different providers that are sending data to a health information exchange, because you can't deliver the wrong information to the patient. So you have to be very, very cognizant of what's happening around patient matching issues.
That's really interesting. We've talked a lot about regulatory and policy levers about how to make exchange work, and it sounds like Kansas has really tapped into a powerful one with PHRs there. Yeah. Mark, really in thinking about PHR and EHR developers, how do they best support patients getting access to their health information?
So there's a number of things that developers can do to help patients get access to their information. But getting access to their information is really just the beginning of the process. In order to make it easier, one is deliver things on mobile devices. Not everybody has a PC, and I think we're seeing, as time goes by, more and more people are living their entire digital life on their phone. So it's absolutely essential that you don't build an experience that's really going to only work for those people who have a PC. Once you give people their information, you have to think about how you give them that information. Many of us have a physical personal medical record at home, basically a file folder with a bunch of stuff from your doctor. Well, an electronic copy of that isn't much better if it's just basically one piece of paper from every time you visited the doctor with whatever information happened to come up during that visit. You need to take that data and create a longitudinal record and go ahead and show it in ways that are meaningful to people and that they can do useful things with and begin to understand. You need to give them context and explanation and education. You need to give them a way to talk about that information, use it to start a conversation with their provider. Not too many people wake up in the morning and say, hey, I want to go look at my medical record. But there are plenty of people who wake up in the morning thinking, I want to be healthier. What can I do to help my elderly mother manage her condition better? All the things people want to do are really verbs. They're actions. They're not just consuming data. So you need to keep that in mind. And the other thing that developers need to really do is embrace things like Blue Button and like Direct that allow those people to take that data and take it to the application of their choice. Because no one application is going to fit everybody perfectly all the time. And so giving people access to their information but not making it easy for them to take that information and go use it in the way they want, in the application they want, isn't really serving them the way that we want to.
Thank you very much. Making sure that the data is usable is so important. I am a semi-caregiver for my father, and when I call him and say, he's in North Carolina, did you get the results of that blood test back? His response is, you wouldn't believe how nice this doctor is. Do you know how... And it goes on and on. He called me on Friday night. Do you know how few doctors would call me on Friday? What are the results of your blood test? Oh, I'm fine. Has no idea. But the doctor is nice and called him on a Friday night. Having that information available is incredibly useful if a prescription needs to get filled. Gilbert. How have you been using technology to communicate with your providers?
So I'll take you to through one of my experiences that I had last year. I was selected as a Kaiser Safety Net Fellow with the Institute for Healthcare Improvement. They choose one fellow in the United States a year that works in a public hospital. A chance of a lifetime, right? Only problem was that my healthcare providers would be 3,000 miles away from me. And they didn't have any physical location that was anywhere near the greater Boston area or Cambridge. So if I want to go to Harvard and I wanted to do this fellowship with IHI, I would have to make a choice. I had three choices. I could go with a different provider, I could go a year without health care, or I could learn to redesign my own care and flip it. What we did was we redesigned my health care. Alongside my providers, I had just learned to grow and love them, and been working with them for over 15 years. I really trust them. And so what we did is we sat down and we looked at all the ways that I needed my care delivered. We looked at MedRec. We looked at my durable medical equipment needs. You have to keep in mind, I see many different doctors for my ailments. Last year I had about 8 average clinic visits in 1 year. That's average, going average. And with the year with IHI, I only had 3. So we redesigned the entire way I received my care. Everything was done online and through phone call communication. Scripts were written up and delivered in time for me to get my medication from California to Cambridge. And what are the results? I look back to 2008 and charted all of my information. We took baseline measures on my lipid panels, liver and kidney functions, and pain. I've never been healthier since 2008 with only 3 clinic visits. And since I've been back in LA, I've continued this process. Yeah. Once again, chasing the triple aim, saving money, enhancing my quality of life, and better health, and a much better experience.
It's fantastic. Thank you. Tim, why is it important for providers like you to be able to receive health information from your patients?
So on the opposite side from Gilbert's story, I have many patients, and they would all like to get their care. Many of them would, in the same way that Gilbert's described, decreasing the number of face-to-face visits. Many of them in a rural area have a difficult time getting into clinic. And if we can increase the electronic communications, we can increase access to a number of patients, make it easier for them to get in to see their care. And frankly, as a provider in a busy clinic, it's much more efficient for us to take care of business that way. One of the difficulties, though, with our current payment system is it really doesn't allow for that. So I think we have an area there with payment reform where we really need to focus on the ability to provide care in that manner in a much more patient-centric way, but still make it financially feasible.
That's very helpful for those of us from ONC to think about. So thank you very much.
And the one last piece, too, when the data are coming in as electronic values, discrete data, patient-reported outcomes, pain data, et cetera, we can use clinical decision support tools, both within the clinic that are provider-facing, but we can also have clinical decision support tools that are patient-facing that will outline their care gaps, immunizations that are overdue, prescriptions that haven't been picked up, those types of things.
Yeah, that's that really reminds me of a trip that Ligia and I took down to MD Anderson, where they had been doing patient mediated exchange for almost 10 years. And one of the things that they told us is it's so helpful for both the provider and for the patient to have an electronic log of exactly what has been said back and forth. So, no matter how many times you tell someone verbally something or how many times you give it to them written down on a sheet of paper, that information may not be remembered the right way. You might spill your coffee on the paper. A million things can happen, and having an electronic copy of it can be very helpful on both sides. Laura, you're working on a pilot to help veterans communicate with non-VA providers using the KHIN portal. Can you tell us more about this?
Yeah, sure. Kansas is a pretty big state. It's 85,000 square miles, and we have 3 very large military bases in Kansas, and we have about 250,000 veterans that live in Kansas, and those veterans get care at the VA facilities, and then they also get care at non-VA facilities. And so about a year ago, the Veterans Administration, the Robert J. Doyle Building in Wichita, Kansas, approached us and said, we really want to see if we can work out a way where our veterans can take the summary of care data that they're receiving through the Blue Button Initiative and be able to send that to their non-VA providers. And we think the way that we could do that is using the KHIN. It's actually called My Kansas Healthy Record is what our patient portal is called. And they said, we'd like to be able to work with you to be able to send that information via direct messaging to all of the Kansas providers that are non-VA facility providers. So we got a little group of folks together. It was a very fun opportunity. We worked with Hutchinson Regional Medical Center, which is a mid-sized hospital for our state. It's about 250 beds. And we used the KHIN, My Kansas Healthy Record, and we used the Veterans, My Healthy Vet. And together we were able to teach veterans in Hutchinson, Kansas, to be able to download from their Blue Button, using the Blue Button, to their My Healthy Vet personal health record. And then they would save that summary of care document and upload it into the My Kansas Healthy Record. And then they would send that via a direct message to Hutchinson Regional. And then Hutchinson Regional, they used a Siemens EHR system, was able to save that into the nursing notes there at Hutchinson Regional so that the nurses had access to the information at the time that the veteran came from the VA facility. So that sounds like it's kind of a convoluted process and did take a little while to work through all of the challenges associated with the workflow, but we really had pretty great success, and we're able to get the information from the VA facility to the non-VA facility using personal health records, and the patients were able to learn how to do it. The veterans were able to learn how to do it. They did it themselves, and I think that it was really a successful project for us to show how not only can we provide the information to the patients, but then how can they really take ownership to make sure that it gets to the facilities where they were going to get non-VA care at. So we were excited about it.
That's, it makes me think about in Kansas and in Oklahoma. I know that in a lot of places in this country think about tornadoes. And last year when the tornado hit Moore, Oklahoma, and the Moore Regional Hospital was completely wiped out. One of the really amazing things about the transfers that happened out of that hospital is that through health information exchange, every single patient had their data available when they arrived at multiple different hospitals in the area around Oklahoma City. And for Kansans, this is also a huge benefit. If their home is ever destroyed, if it ever hits an urban area, that this data would be accessible anywhere that they can get an internet connection.
Just to make a comment about that, our exchange has been fairly successful. We haven't struggled as much with the interoperability problems that other places have. But one of the things that we get from all of our hospitals is what's called an ADT feed. It stands for Admit, Discharge, and Transfer. So we know immediately when a patient's been registered at a hospital. So one of the things that happened is that we realized that we could use the exchange to find patients in an emergency. Yeah. Because before, patients may be taken to multiple hospitals all over the region. Well, now the exchange knows that the patient's actually been registered at the hospital, and by searching in the exchange for the patient, we can find which hospital they've been taken to in the event of an emergency. So I think about that like the situation in Boston where patients were taken to all different locations and they couldn't find them. Well, now with health information exchanges and ADT feeds coming in, we can find those patients immediately.
Yeah, it's a big deal, and it's often overlooked. Emergency preparedness and response and how we support people. You never realize how much you need it until it's too late. And the good news with consumer-mediated exchange is that we're getting there a lot faster. We'll have this back up. Gilbert, what would make it easier for patients to send their information to providers?
You know, Lee, I think the biggest myth that we have is that people living in underserved communities or under standards that are low socioeconomic will not use the technology if they're given the technology. In my experience, I feel that we need to unleash the technology. Later on, we'll be talking a bit about expanding broadband coverage in rural areas. This is America. I'm sure we have satellites that can track a squirrel in Machu Picchu. I feel that if you give patients what they need, you give them the right tools, that they'll make the wise decisions and keep themselves healthy. I've never met a patient that didn't want to be healthy. I think about other industries. Think about what Uber has done to transportation. And what do? They give their drivers iPhones. Why can't we give our patients iPhones?
That's exactly right. And again, it just goes to that empowerment piece. I mean, some of the folks that there's always been the skepticism that there would be use and understanding of what this is, and we have found it to be completely the opposite. There is a very high degree of technological savvy out there in the world.
And I'd just like to add to that, too. The video was a great example of humanizing the experience and making sure that we're always connecting those dots with patients and helping them realize why it's so important to watch their kids and their grandkids grow up. And so always bringing back the human aspect of this is very important.
Mark, what are the biggest challenges facing EHR and PHR developers related to patient-mediated exchange?
So I think there's a couple of specific things that are posing present and looming challenges for patient-mediated exchange. The first one is very tactical and really a technology issue, and that has to do with trust bundles. And I won't get too much into the bits and bytes of it because not everybody here is a developer, and I don't want to put anyone to sleep. But really, use the Blue Button Trust Bundle. Use trust bundles that are dedicated to patient connections. These providers need to get away from thinking that they can use direct trust and call the job done. Sharing data with patients is not an afterthought, and that seems to be a little bit of the attitude of some of the players. The other thing, and this is going to take a lot more work, and this isn't just a simple technical issue, is how do you bring that data into the clinical workflow? I mean, patients are say we can get patients to be able to easily and quickly get all their health data they want, whether it be from other providers, labs, their pharmacy, home health care workers, behavioral health information, social services information from Google Fit, Apple Health Kit, what have you. How do you get that in the hands of care providers in a way that they can work it into their workflow? It's not really something they're prepared for. So you can't just dump it all into the electronic medical record and not distinguish it, because then it's just this massive data where you can't tell the difference between what's happening in your hospital or that was your direct care to this patient versus information that's been forwarded along a couple times. So really, the systems have to get better at ingesting the data, they have to get better at parsing the data, but most importantly, they have to get better at presenting the data in ways that are useful at very specific parts of the clinical workflow. What data is going to be important to an ED doctor is not the same data that's important to a primary care physician or a rheumatologist or an oncologist. So it's going to take a real partnership with the healthcare providers to figure out, okay, this data's coming. It's, all the work's being done. It's going to happen. Patients are going to have this data, and they're going to want you to have access to it, and they're going to want you to consider it in your decision making. How do we help you consume and use that data usefully?
Absolutely, that's a really important point. It's, when we started recognizing that this data is actually moving, you do all of a sudden need to know, well, who put this data in? Which part of it came from which provider? And those are important parts, and those are all pieces that I think we're really starting to look at to get a little bit more constrained in our thinking about some of those distinct elements about how we identify where the data is coming from and when. Tim, you guys originally had low participation, and what did you do to change that?
When I started my most recent move and started practicing at a new clinic, we had about 30% of our patients had signed up for our patient portal. And we didn't really have a particular plan in clinic for how we were going to increase that. And frankly, it really wasn't a priority to increase that number. There were a couple of us in clinic that realized the potential for patient portals, both for the patient benefit as well as for our clinic efficiencies. And we took it on as an improvement project, and we chartered it and went through a formal process for that. What we started off doing, even before we started that process, though, was to have just a meeting of the leadership. We had our lead physician, our chief nursing person, representative from the front desk staff, our financial and executive director. And we got a small group of people together, and we agreed that this was going to be a priority. And I've seen this play out over and over again at other clinics, that until you get that group of people on board and all committed to this improvement project, it's not going to happen. Once we got that group in place, then we had an all-staff meeting. We went through some of the myths. There's a lot of misunderstandings, particularly among physicians, about what patient portals are and what they aren't. There were a lot of concerns, anxiety around the front office staff that they're going to get swamped by phone calls about medical records and something that's wrong in their problem list, et cetera. And really the research, some of which we heard about earlier, has just borne out over and over again that it doesn't change that much in the office workflows. If anything, it increases efficiency slightly. And so we went through some of those myths and then answered questions. And then we went into a training program. Unfortunately, even the best EHRs right now don't have great graphic user interface. Which buttons do you click to release a lab result to a patient? How do you send them a message about their CBC result? So there's a certain amount of training that needs to go along with that. And until the office staff is using that patient portal tool over and over again on a regular basis, it just doesn't become familiar. So you've got to kind of push through that initial process to the point where they're using it on a regular basis. Yeah. And then we went through several PDSA cycles where first we had the rooming staff trying to get the patients to sign up for their patient portal and enter their access code. We got a little bit of a bump. We got up to about 40% with that. And we started giving out the access codes at the front desk for other patients. We got up another 5 or 10% of our patients with that. And then we realized that really it wasn't going to be any one group of people in the clinic, that the providers were going to have to be talking it up with their patients because they often had a great relationship with the patients. The rooming staff needed to take a couple of extra minutes at the beginning of the visit with a new patient to get them signed up right in the exam room. The front office staff had to be talking it up. There really had to be a team play. And then, as we heard earlier from Mark, the workflows, we needed to redesign some of the workflows for lab result releases. We could send a message through a patient portal much faster than sending a letter, but the staff were familiar with doing the letters. Yeah. So we had to redesign the workflows, and we were able to get up. We're now about 50 to 55% of our patients are on with the patient portal. And I've been working recently with Molina Healthcare, who just came onto our electronic health record at Ochen. And they had an interesting situation. They brought about half of their clinics up without the patient portal, and they got used to the workflows without it. And they brought a couple of other, and they had about 40 or 50% of their patients using it. And then they brought a couple of other clinics up, and from day one with those clinics, when they went live with their EHR, they had the patient portal built into every single workflow, and they've hit about 90% participation.
Wow. It's really impressive. So, I think now we're going to try something a little different with some questions from Twitter. We're actually going to, of course, I got so comfortable, we've just run right on and taking up a lot of time. But anyway, thank you all very much. This was a great opportunity.
I want to. It's working. Is this on? Can you hear me? Okay, great. Thank you so much to the panel for not just helping us to see how access to Blue Button data is actually being used in practice to support patients and patient care in a really important ways. My two favorite quotes from the session are shifting the discussion from what's the matter with you to what matters to you, and sharing information with patients should not be an afterthought. So those are my two quotes that I will be requoting, so thank you for that.